Use this one. Good evening, everybody, and it's a pleasure to be back again this year. And I see a lot of enthusiasm, especially after lunch. And I will be speaking on a topic which is not very dear to all of us, but very important. And why I say so is because skin infections are one of the most under-recognized in intensive care unit, one of the most underdiagnosed, and one of the most poorly managed infections. And you will understand why I am saying so once I go through the presentation. And it's a brief presentation, so it will be a brief overview. And I have tried to make it simple and tried to cover the important aspects of skin involvement in the intensive care units. So I will not be going into the details of the classifications and all, but broadly speaking, if you look at a skin and soft tissue infection, which is a SSTI, they can be of various types, like a surgical infection, a diabetic foot, or an infected wound, infected ulcer, any abscess, cellulitis, and then necrotizing skin and soft tissue infections. Now these are the dangerous ones, though any of these infections can become overwhelmingly fulminant and can lead to sepsis, septic shock, and multi-organ failure. But necrotizing infections give you very less time. So skin infections can be mild to severe. They usually reflect a systemic process, or sometimes they are localized to the skin. But important is that we must be able to differentiate them before you approach a patient of any skin lesion or any suspected skin involvement. You should be able to differentiate the non-infectious causes of skin lesions. For example, vasculitis rash and sarcoidosis, any cancer. There are cutaneous manifestations of cancers like lung cancers, dermatitis. You should look at drug rashes, venous stasis changes, thermal injuries, contact dermatitis, chemicals, because in the ICU you see a lot of medicines which cause drug reactions and drug eruptions. So, for example, this is one such patient admitted to the ICU. Any comments what it could be? Sorry? It is only on one left thigh. So this is basically a patient of contact dermatitis. Now this patient has an allergic contact with something and then developed fever for something else and got admitted to the ICU. And everybody was focusing on something related to this. But it actually was a contact dermatitis unrelated to the presenting problem. So you should be able to understand what this kind of changes are. Another patient, yeah, so this is very common, fairly common. It is red, swollen. Sometimes you misdiagnose it as a cellulitis, but these are very common changes, venous stasis changes in patients who have these poor lymphatic drainages and dependent edema in the ICU. So skin and soft tissue infections are basically infections of the epidermis, dermis, subcutaneous tissue, and further deep down, the necrotizing infections which involve the muscles. There are basically two types, uncomplicated and complicated. Uncomplicated are those where the patient is healthy looking and just does not have any signs, symptoms of a systemic involvement, no fever, nothing else. This is an uncomplicated patient. A complicated skin and soft tissue infection is 2, 3, 4. Any patient having fever or any patient who is toxic looking, tachycardia, low blood pressure, or any patient who is developing a shock or multi-organ failure with a skin lesion. These are the patients who warrant immediate attention or maybe admission, and you should be clear. So, if you compare a soft tissue infection versus a skin infection, soft tissue infections can be rapidly progressive. A multi-organ involvement may develop and which can be quite rapid. They have a very high mortality. There is a high rate of associated bacteremia, which means you can have a blood culture positive patient. They need a very aggressive treatment. There is no time to wait, and I'll show you a few cases also. and they may need surgical debridement or drainage. So that means you have to involve the concerned vascular team or the plastics team very early. So these are basically the types of the varieties of infections, and I'll quickly go through them. This is impetigo, this is ecthyma, erysipelas, cellulitis, folliculitis, furunculosis, and a carbuncle. Now these are fairly uncomplicated things. You can see any patient walking down in the OPD. These are usually OPD presentations. But if you look at the complicated ones, these are infected wounds. For example, there was a trauma and this patient got an infection here. There can be a post-operative wound sepsis. There can be diabetic foot infections, venous stasis, ulcers, as I showed you the example. There can be ulcer and infection here. There can be blood pressure sores. There can be perianal cellulitis, very important to identify early because it can lead to necrotizing perineal infections or gangrene, Fournier's gangrene. Then you can have deeper soft tissue infections. For example, a burn patient having an infection or a streptococcal or staphylococcal infections. So when to consider? It is complicated, it is easy because the patient will be toxic, patient will have a dirty looking wound or a rapidly progressive wound, and one should be able to identify that yes, this patient needs admission, antibiotics, maybe debridement, and I need to wait and evaluate the patient. So just don't neglect any skin findings in any patient. So this is a clinical scenario, 34-year-old call center guy, Saturday night, scuffle at Hard Rock, and abrasions on the knee. You can see there's an abrasion on the knee. He washed the feet next day. There is redness and warmth over the next few days in the area of abrasion. And then after a few days, 2 days, he noticed a fever and there's a red streak noticed along the medial thigh. Anyone? It's not difficult. Yeah. So this is a classical presentation of a cellulitis which is neglected and often preceded by a skin irritation or trauma. And there is usually skin involvement, dermal and subcutaneous tissue. The borders are diffuse and non-elevated. In erysipelas, they are elevated. So that's how you differentiate. And most of these infections are due to streptococcus or staphylococcus. So important is antibiotic therapy early, and this is just to show you the various levels of skin, and we are talking about the level of skin and subcutaneous tissue. We are not going there. This is the region which is cellulitis, and erysipelas is limited only to the superficial skin. So treatment, we know it's elevation is very important. Antibiotics, gram-positive cover. We'll talk about this. And important thing is to always see in a cellulitis patient, is there a risk factor? Because cellulitis is one such problem which recurs. And if you encounter such a problem, what is this? Very common. कुछ भी बोल दो. Fungal infection, yes. It is a fungal infection. This is tinea pedis. So very common in diabetics, in neglected patients. You must treat tinea pedis because this can lead to fulminant sepsis, cellulitis. Never leave these patients alone. So these are the common skin pathogens. If you look at this, you can read it later also. If you look at this chart more closely, most of the infections are due to staph or streptococcus. And only in a patient with a particular kind of folliculitis, which is whirlpool, there is a pseudomonas. Otherwise, most of the infections which are in the skin are due to streptococcus and staph, unless the patient has a nosocomial skin involvement, which we'll discuss later. So these are the pathogens. Sometimes you can have, complicated infections. For example, you can have a patient with IV drug use where you suspect a MRSA or pseudomonas. For example, you can have a human bite, Ichinella cordons. Cirrhosis patients usually have Campylobacter. Diabetics have Streptococcus, staph, and gram-negative. So diabetics tend to have a multibacterial colonization and then can develop infections. This is just to tell you that you have to be very clear in what type of infection you may be dealing with so that the antibiotic choices may be guided. So what can you expect? Usually the superficial infections are gram-positives. So you can safely give a gram-positive cover unless you have a risk factor for other organisms. As you go deeper down into the tissues, they become anaerobes and gram-negatives become common. So this type of cover we are looking at, and one should be careful. Antibiotic therapy, not going into a lot of detail, but you should be able to cover gram positive and gram negatives and anaerobes if the infection is deep. And these are the 10 Ds of antibiotic therapy. This is valid for any infection in the intensive care. One should be able to dose early. So you should not wait for somebody to tell you that give antibiotic. If you feel the infection is complicated or can become complicated, give antibiotic early, hit hard early. Data, the antibiotic data is important in your intensive care units. Drug penetration, dosing, dilution, duration, drug resistance, you should consider. Drug toxicity also, whether the antibiotic which I am using can the antibiotic lead to skin problems, de-escalation and drug interactions. So this is very important in any antibiotic therapy. So, and particularly with the skin involvement. So this is a postman with fever and draining foot ulcer. Any comments? Diagnosis? It is very easy. Foot ulcers, very common. Neuropathy. Diabetes, very good. So diabetic foot infections. This is a very common presentation because diabetes is an epidemic nowadays, and usually due to peripheral neuropathy and vascular insufficiency, which is common in diabetics. You usually get a mixed flora because these patients present to us late. So streptococcus staph and a mixed flora is very common, and usual therapies, debridement, antibiotic, wait, watch, infection control. Don't let another infection happen. This is what you do as with most other infections, and this is the patient who has recovered. This is another common entity in the intensive care, furunculosis. As you can see, this gentleman has developed abscess after a small folliculitis. Folliculitis is an infection of the hair follicle, but in the bedridden patients, in the ICU patients, this is pretty common. Usually risk factors are diabetes, steroids, staph aureus is common. Again, treatment is drainage and antibiotics. So antibiotics are not recommended for everyone. OPD patients, most of the skin specialists you see don't give antibiotics unless they suspect an infection. But in our settings, usually most of the patients require antibiotics because they are pretty sick. They are in the intensive care units. Sometimes they may have lesions in the areas which are difficult to drain, like face, hand, genitalia, and sometimes they don't improve after insulin drainage. There is rapid progression, severe disease, and comorbidities. So these all things are pretty common. So antibiotics are recommended for these patients. And if you look at once you are planning for debridement and you have done the debridement or you're planning, you can use these antibiotics and which of them is available. And please remember that there is not a lot of data for tigecycline because I see some units are using tigecycline for skin, but there's a red warning by the FDA not to use tigecycline in skin and soft tissue infections. So these are the antibiotics. Another case, this is a 36-year-old man who turned his ankle. Pain, nausea, vomiting, fever after after 5 hours, he developed chills. Then at 18 hours, this patient comes to the ER with severe ankle pain, X-ray is normal, thought to have flu, WBC count is this. At 24 hours, redness starts spreading, wife thinks he looks blue, there is temperature, leukopenia now, and creatinine is 2.4. Any guess? Rhabdomyolysis. Okay. Rhabdomyolysis is such a rapid multi-organ failure. And he doesn't have a crush injury or major trauma. Why would rhabdomyolysis happen? Then admitted, you have to admit such patient. We admitted the patient. The BP starts falling. Hemoglobin from 15 became 18. redness to the knee, creatinine is 4.2 at day 3. So what it could be? So there is typically a hypotension, capillary leak occurring, there is an infective process going on, there is a leukopenia, multi-organ involvement. So definitely this is a day 5 picture of the same patient. You can see there is extensive skin involvement with bullae and necrosis of the skin. We managed the patient's antibiotics, gram-positive, cover was given, debridement was continued, skin grafting was also done in this patient. Anti-streptococcal antibody titer was positive, and this was a classical case of streptococcal necrotizing fasciitis and streptococcal toxic shock syndrome. And the man presented with twisting of the ankle. So that's what I want to emphasize, that sometimes they may not give you a clear history of an infection, but you have to go by the scenario which is happening, the way the patient is evolving. Sepsis with shock patients, within 15 hours, 24 hours, there has to be something major. Otherwise, sepsis gives you time. So this is pre-debridement, post-debridement, patient is better. There are clinical criteria, not going into the details. There are two types of toxic shock syndrome, both streptococcal and staphylococcal, and both almost are similar in presentation. This is the criteria for diagnosis. Usually it is simple. You look at the rash and the fever and the lab multi-organ involvement. You should be able to understand. Any comments on the left side? What is this? So I'll be quick because I don't have much time. This is the maculopapular eruption. It looks very normal to you, but this is an early sign of a toxic shock syndrome and resembles a sunburn. This is very common. Another patient with a macular rash. This is another important early warning sign of a toxic shock syndrome. Eyes, any comments? This is known as conjunctival suffusion. Hands, very good. Desquamation of the skin. So these are all very early warning signs of staphylococcal or streptococcal toxic shock syndrome. Usually you diagnose them with cultures and all. Please remember, for the diagnosis of staphylococcal toxic shock syndrome, you don't have to culture positive. It is a clinical diagnosis based on the criteria. Because the blood culture is negative in almost 95% of the patients. So you have to go for tissue diagnosis. You take a tissue swab or a biopsy, and then in 80 to 90% of the patients, you are able to recover the bacteria. Management is manage the shock, supportive care, source control, antibiotics. These are the antibiotics. Please remember, they have included clindamycin in every category. Why? Very good. So it's a toxic shock syndrome. Clindamycin is the antibiotic which has got antitoxin effects on gram-positive bacteria. So we combine it with these. So MSSA you use Clinda plus oxacillin, MRSA Banco plus Clinda, and for patients with unknown cause where you may be having some gram negatives also, Banco, Clinda, and VL-Bili or carbapenem. IVIG has always been controversial. There has been no clear recommendation, but for patients who are a rapidly progressive multi-organ failure, severely sick patients, where you know the diagnosis is pretty clear to you, you can use IVIG. There are some reports where it improves outcome when used early. So I will be talking about the deeper infections, which is necrotizing fasciitis now below, involving the muscles. So necrotizing infections are often in the perineum or lower extremity, and they are less purulent. So pus discharge is not there. They spread very rapidly. Within a day, the whole leg is gone. Associated with usually trauma, vascular disease, diabetes, surgery, tissue necrosis, and the pain is disproportionate. Skin lesion is very small, and the patient is crying. And most of the time, people will say this patient has got some problem, is just malingering. But the pain is severe, and after a few hours, there will be no pain. anesthesia, because all the nerves are damaged by that time. So this is very important. Necrotizing fasciitis, gas gangrene, they present like this. They can be monomicrobial or polymicrobial. Type 2 is monomicrobial, looks like a streptococcal toxic shock syndrome. These are the features. They can be oral. You can see this leg with blisters. There is a diabetic woman with rapidly spreading gangrenous infection. This is how it looks. This is how it looks after debridement, necrosed muscles. So how will you differentiate it's a cellulitis or a necrotizing fasciitis? So important thing is that pain is very severe in necrotizing fasciitis. It's a rapidly swelling, rapidly spreading swelling and inflammation. Cellulitis takes time, 2 days, 3 days, 4 days, gradually spreading. Necrotizing immediately, within a day, the patient is gone. Bulle is usually very early. In cellulitis, in late stages, you will see bulle. Necrosis is there, elevated CPK, creatine kinase, because the muscle is injured, which is suggestive of muscle involvement. Toxic shock syndrome and risk factors. If you have a varicella, for example, and then a patient is admitted, develops a skin lesion and rapidly progresses, it could be necrotizing fasciitis. NSAID used. So diagnosis is usually clinical and by tissue biopsy. You can do a tissue biopsy easily, bedside also. And CT MRI, you see the edema along the fascia. So this is very important that you do a CT or a MRI if the patient is stable. Then you can look at this image. You can see there is enhancement. There is a whole thickening of the abdominal wall. This is the buttock, and you can see this spreading in the gluteal region. So this is a rapidly spreading infection. Then obviously surgical debridement, antibiotic therapy. You can use BLBLI plus clindamycin. You can use carbapenem plus clindamycin. In MRSA you use linezolid or vancomycin plus clindamycin. And IVIG again, there is a very weak recommendation, but for very sick patients we intend to use it. So coming to an important one, what is this? What you can see? What is this? Just tell me, gram negative, gram positive. It is easy. Gram positive rods, but they are anaerobic. So anaerobic medium has to be required. Otherwise, you will not be able to culture them. So that's how they are missed. So it is Clostridium infection. Nobody wants them to have because mortality is very high. Most of the patients die before they even reach the ICUs, and even if they reach the ICU, they don't make it because the infection is rapidly spreading. It looks like a toxic shock syndrome, but you can differentiate because once you touch the patient, the skin lesion, there is a crepitus. You can feel air because it's a gas producing organism. And that's how you differentiate. There's a lot of necrosis, pain, toxic patient, hypotensive, no response to fluids, vasopressors, albumin, nothing is working. So early antibiotic, piptazo plus clinda, debridement, mortality is 67 to 100%. So if you are not very proactive, most of the patients die. And majority of the deaths occur in 24 hours. So very aggressive treatment has to be. There are patients which we have salvaged also, so not to discourage anyone, but this is how they look after a trauma. Classical history: fall on the road, knife injury, dagger injury, bullet wound, and then this kind of a picture. So now you have to tell me, what is this? Quickly. You can see muscles. This is all muscle necrosis. This is a peripheral blood smear of a patient of hemolysis. What is this? Red is reticulocyte. What is blue? Blue is spherocyte. What is this? Black. Looks like a ghost. It's a ghost cell. Ghost cell is a lysed RBC. So if you see this picture, this is the classical of hemolysis. And what is this? Neutrophil with toxic granules. So it is very important, one should always try to see what these people report. And that's why I wanted to show. And what is this? This is the MRI. What does it show? Air in the buttock. So this is the injury in the buttock, a knife injury, and then this happened. There is air, and ultimately this patient had to be amputated below this hip amputation. The patient was able to make it. So what is dress? Party dress or any other dress? Anybody? Now these are non-infectious things. I just wanted to discuss these. In the interest of time, we'll be brief. Very good. So extremely important to know this because it is known as drug reaction with eosinophilia and systemic symptoms. It is a hypersensitivity reaction to a new drug. So the important is history. The patient must be taking the drug 2 to 8 weeks prior to the onset of rash. So it is not an acute phenomenon, number one. And the patient will come with a skin reaction with pura systemic involvement. There will be fever, generalized lymphadenopathy, multi-organ failure, abnormal deranged liver function, kidney function. You will feel the patient is in sepsis, there is a toxic shock syndrome, but no, you have to take the drug history. And majority of the cases are due to anti-seizure medicines, ATT, allopurinol, sulfonamides, minocycline and vancomycin. And all of these drugs are commonly used in the Indian ICUs or Indian OPDs. So very important to recognize this. And diagnosis is usually by a DRESS score and drug exposure history. Treatment is steroids, cyclosporin or IVIG. So that's why it is important because most of the time these are diagnosed as a bacterial infection, given antibiotics and they die. So if you recognize this, important is that recovery is 100%. If you recognize this, patient will be fine. After 24 to 48 hours, they start improving and you can send them within 5 days. Otherwise, they will die. What is this? It's easy. Morbilliform skin reaction due to stress. What is this? Macules. Please see this is very common. Macules. Morbilliform skin reaction. Both are due to stress. What is this? There is a female. I intentionally wanted to show this. So don't get confused. Please take the history. You can easily make out if it's a SLE rash or not because the patient will be having loads of other symptoms by which you can correlate it's a vasculitis or not. So another important, my last few slides, Steven Johnson and 10. Most of the people start talking about this. They are again rare skin reactions caused by medicines. And they are characterized by extensive necrosis and detachment of the epidermis. So they are usually limited to the epidermis. So the skin starts peeling off. And in cases where there is less than 10% involvement, they are known as Steven Johnson. More than 30% involvement, 10. And between 10 to 30, overlap. And these are the drugs. Again, you can see all of these drugs are commonly used in our OPDs and ICUs, including diclofenac, doxycycline, quinolones. I diagnose a lot of patients of COVID with this because in COVID they always give doxycycline or these medicines. Diclofenac, another quinolone, etorecoxib, the favorite nowadays the NSAIDs for the orthopedicians. So important thing is that Steven Johnson starts with these, target lesions. You can see bullet-like lesions, target lesions. So, and then becomes confluent. And gradually vesicles and bullae start developing. And according to the strength of involvement, you can label them Steven Johnson or 10. Typical is mucosal involvement. You can see the lip starts, there is a blistering, there is erythema, there is skin detachment, and this is 10. So this is how they evolve, but most of the time they are diagnosed as a bacterial infection. So important is to recognize. So my final key points, SSTIs have a variable presentation. They can be simple or complicated. Please take the history. risk stratify the patient. Patient has to go to the ICU or not, because these patients can have a rapidly progressive course. We take these patients who have skin involvement and toxicity into the ICU because we know things can go wrong pretty soon. Understand the risk factors, etiology, consider the non-infectious causes, always consider differential diagnosis. As I told you, DRESS, 10, Steven Johnson, vasculitis rash, contact dermatitis. Why it cannot be this? Why only staph or streptococcus? So, surgical intervention is the key, early intervention, and after the intervention, infection control. Because skin infection cleared, then again something happens. So, questions? Can we take one or two questions? Yes, please. Anybody?
Sir, I want to ask something about infection control in general, not about the escape. There is a saying, hit hard and hit early. This saying is not against the antibiotic stewardship.
No. Antibiotic stewardship is the 10 Ds of antibiotics.
Sorry.
Antibiotic stewardship is the 10 Ds of antibiotics, which I showed you. We are talking about only one D. So that is one component of the antibiotic stewardship. So hit early, hit hard is for selected group of patients where you have a fulminant suspected sepsis, where the patient has a potential to go into shock. That's where they say hit hard, hit early. It is not a patient who is coughing in the OPD and you give them a meropenem. So that is the difference. I just want to give you a brief overview. So hit hard and hit early is for a selected variety of patients, and that is stewardship. Please answer this question. Most appropriate statement concerning the pathophysiology and clinical presentation of necrotizing fasciitis. Yes. Which one? Pain usually precedes skin changes by 12 hours. No. This A. Skin is likely to appear normal. No. C. Yes. So pain disproportionate. So the answer is C. The box has moved to E. Sorry. Okay. Question 2. The most appropriate statement concerning the diagnosis of necrotizing fasciitis. Unlikely in the absence of crepitus, creatinine kinase diagnostic method, laboratory indicator of NFS strong positive. Yes. Yes. So this I have told you that if the creatinine kinase is elevated, then you suspect a muscle involvement. Again, I am focusing on necrotizing because these are the patients who will trouble you. These are the patients who are not going to make it. Which is correct? Linezolid is an antitoxin. Exotoxin. Okay, what about B? C? ठीक है जी? You can read it. You don't have time to go into detail. But last question. Most appropriate statement regarding necrotizing soft tissue infection include. So type 2 infection is monomicrobial, type 1 infection is unlikely to occur in perineum and trunk, type 4 infection can occur in any patient, type 3 infection the commonness is not gram-negative organism. So answer is, so type 2 is a monomicrobial, which is a toxic shock syndrome like picture. Okay? See, microbiology is very important for you to learn, because if you are giving IDCC and all, these are the questions which will come. Okay, thank you. Questions? Or we can take them later. Easily understood. Thank you. Thank you, sir.